My lady, good afternoon. Can you see me and hear me?
I can, thank you, Ms Blackwell.
Thank you very much. My lady, this afternoon's witnesses are Professor Leah Beckerez and Professor James Nasru. May they be sworn, please.
Let's repeat after me, please. I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Okay, after me. I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
that the evidence I shall give
that the evidence I shall
shall be
give
the truth,
shall be the truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you. Take a seat.
Thank you.
Professor Beckerez, will you give your full name, please?
Laia Beckerez.
Thank you. And Professor Nasru, your full name, please.
James Nasru.
Thank you both very much and welcome back. I understand that you have both previously given evidence in Module 2 and you have kindly agreed to provide Module 10 with reports on unequal impact of the pandemic in relation to your areas of expertise. We will begin with your joint report, please, and then move on to deal with your individual reports. Your joint report is on the impact of the pandemic on racial and ethnic inequalities across the UK. You should each have a copy of the report in front of you. For our reference, it's INQ 000588214. Can you each confirm, please, that that is the expert report that you have provided jointly for the purposes of Module 10?
That's right.
Yes, it is.
Thank you. And that the facts stated within the report are true to the best of your knowledge and belief?
They are.
Yes.
Thank you. And that any opinions that you have stated in the report represent your true and complete professional opinions?
They do.
Yes.
Thank you both very much. By way of introduction, Professor Beckerez, you are Professor of Social Science and Health at the Department of Global Health and Social Medicine in the Faculty of Social Science and Public Policy at King's College London. You have researched and published on the role of structural and societal determinants in leading to health inequities for over 20 years, and this includes examining the unequal impact of the COVID-19 pandemic on LGBTQ+ populations and on minoritised ethnic groups. And you serve as a member of the academic reference group of the NHS Race and Health Observatory. And Professor Nasru, you are Professor Emeritus of Sociology at the University of Manchester. You were previously a Fellow of the Academy of Social Sciences, a Fellow of the British Academy, Professor of Sociology at the University of Manchester, and Professor of Medical Sociology at University College London. And for more than 30 years, you have conducted research on issues of inequality, social justice, and health, with a focus on ethnicity and race, ageing, gender, and the interrelationships between all of those. Thank you both very much. And finally, Professor Nasru, amongst other roles, you were founding director of the interdisciplinary Manchester Institute for Collaborative Research on Ageing and a member of the governing board of the NHS Race and Health Observatory and co-chair of its academic reference group. The report which you have provided for Module 10 builds on your Module 2 report and really continues where that left off. In the Module 2 report, you discussed the situation across the UK so far as racial and ethnic inequalities were concerned going into the pandemic. And in the Module 10 report, you discussed the impact of the COVID-19 pandemic on racial and ethnic inequalities, and you describe the existence and extent of inequalities and discuss the causes of those inequalities. At paragraph 2 of your report, you say that you are not consistent with terminology throughout the report because you describe a reflection of the categorisation of ethnicity that occurs in the evidence that you cite. So you repeat the way and the manner in which that occurs in the research papers and administrative data that you've come across. In Module 2, you concluded that people from ethnic minority groups were at heightened risk of becoming infected with COVID-19, something which you both agreed was foreseeable and which the government took too long to recognise. You reflect a lack of data, a lack of action, and you recommended a framework for each government of the United Kingdom for considering those at risk in an emergency. The first question I want to ask, and I'll come to you, please, Professor Nasru, is in relation to race equality legislation. Is it broadly similar across the nations of the United Kingdom, or are there differences? And if so, are those differences significant?
So the legislation is broadly similar across the different nations of the UK. The population composition varies across the different nations of the UK, but the legislation is similar.
Thank you. Within your report, do you present evidence, however, mainly from England, and is that due to the availability and coverage of the data sets?
That's correct. So the majority of data that are available to describe the situation of ethnic minority people within our societies is broadly drawn from England. There are some exceptions, but broadly from England. But even within England, there are significant data limitations.
Thank you. And overall, in your report, do you find that there have been clear and stark ethnic inequalities in infection and mortality rates, in testing, monitoring and vaccination, and in health and health behaviours and healthcare?
Again, that's correct. In almost every area that we examined, we found important ethnic inequalities.
Thank you. I'm going to remain with you, if I may, Professor Nasru, to discuss the increased risk of infection and COVID-19 related mortality. Paragraph 16, you tell us that in relation to data gaps, prior to the COVID-19 pandemic, there were no adequate sources of information on the health of ethnic minority people in the constituent countries of the UK, nor for the UK as a whole. Is that right?
That's correct.
And it wasn't until June of 2020 that national data covering England and Wales was published on the extent of those inequalities.
That's also correct. So it wasn't until ONS did some quite heroic research doing data linkage, and they had to use data linkage because other data sources weren't available in order to describe differences in risk of mortality. Can I just add a tiny bit of context, which is that data sources historically have existed, in England at least, to describe ethnic differences in health across different ethnic groups in the UK. But those data sources effectively ended data collection in the early part of the 20th century.
Thank you. And do there remain serious limitations with data sources?
So consequently, there remain those serious limitations, and they exist despite the data linkages that have been made.
Thank you. Proximal factors related to ethnic inequalities in risk of infection and mortality, what were these?
So there are a range of factors that are described as being important contributors to both risk of infection and, of course, following risk of infection, risk of mortality.
Yes.
So these include where people live, the kind of housing they have, the various socioeconomic inequalities that they face, area deprivation, types of jobs, income, and so on. The types of jobs that people did and how those types of jobs place them at greater or lesser extent in terms of risk of infection. And crucially important also was pre-existing health inequalities.
So including chronic illness?
Chronic illnesses, in effect, yeah.
Yeah. And when you refer to those factors, are you referring to the same or different elements of clinical vulnerability?
So they could be, some of them could be described as clinical vulnerability. Clinical vulnerability, as I understand it, requires a kind of formal measurement of a range of conditions
Yes.
that people might have. We in some of our research, have used a slightly less formal measure to try and assess the extent to which people have poor health.
Thank you. Taking some of those factors individually, is it noteworthy that ethnic minority people were more likely than white people to be employed in key worker roles and more likely to be working in client-facing roles and consequently more likely, therefore, to be exposed to the virus?
Yes, again, that's correct. So there are a whole range of employment positions where ethnic minority people are more likely to be present and led to a greater exposure to the virus. And in some of those employment conditions, ethnic minority people appear to be less likely to have access to PPE.
Thank you. We'll come on to deal with that in a moment. And in terms of geographical areas, was it much more likely that ethnic minority people were living in densely populated urban areas rather than white people as the pandemic began?
Yeah, so ethnic minority people, geographical concentration is in more densely populated areas, in urban areas. It reflects the history of settlement of migrant populations and then ongoing employment opportunities, housing opportunities, etc. I think in the early stages of the pandemic, very important was the concentration of ethnic minority people in London, where early exposure to the virus was common. Yeah.
And in addition to the urban or deprived areas, was there also a greater proportion of ethnic minority people in overcrowded housing?
Again, overcrowded housing was a risk factor for infection and for mortality. Ethnic minority people are more concentrated in overcrowded, multi-generational housing. This type of housing was particularly important when it was present in deprived areas. So it's overcrowded housing in deprived areas that was crucially important. Importantly, once you take into account a range of other factors, overcrowded housing itself did not contribute to a massive extent, did not contribute to a great extent to the ethnic inequalities in risk of mortality. So the question is, what does overcrowded housing represent? And in effect, it represents deprivation.
Thank you. Moving then to deal with the risk of COVID-19 related mortality, you tell us at paragraph 24 and 25 that it's noteworthy that prior to the COVID-19 pandemic, mainstream academic and policy work generally ignored or downplayed the significance of ethnic race inequalities in health, and that the question of the risks experienced by ethnic minority people emerged during the early stages of the COVID-19 pandemic, when anecdotal evidence reported in mainstream and social media began to indicate meaningful ethnic inequalities in outcome. Is that right?
Yeah, so in the early stages of the pandemic, there were some very important media reports, some very important media-led investigations, as well as some small-scale studies that all began to reveal the extent of the ethnic inequality and risk of mortality.
Thank you. And then later, towards the end of April 2020, there was evidence published by The Guardian and Times newspapers based on their own research, which indicated that ethnic minority people represented 19% of deaths recorded in hospitals, and that areas with a higher proportion of non-white ethnic minority people had experienced higher death rates.
Yes, that's correct. That's what I was referring to just now.
Thank you. And then later on, still in June of 2020, the ONS published their data.
Yeah, so in the period, I'm not sure when they started that research, but over a very short period, they then produced the linked data set and published the national figures.
Thank you. Could we display, please, in your report, which is INQ 000588214, there we are, thank you, page 8, highlight figure 1 at the bottom of the page. This is a figure that shows ethnic and religious inequalities in risk of COVID-19 related mortality in England for the period 24th of January 2020 to the 11th of September 2020, age-adjusted hazard ratio compared with white British people and Christians. Can you explain what we are looking at here, please, Professor Nasri?
Yeah, so because it's a hazard ratio, it's risk compared with white British people. And so the white British group are, in effect, represented by the line 1, so the horizontal line 1, which in this case is at the bottom of the graph.
Yes.
And any bar that is above the graph shows an increased risk to the extent of the size of that bar. You'll see there black eye bars attached to each of the bars, and those represent statistical confidence. So it's not certainty, but statistical confidence. And if that bar does not cross the line 1, the horizontal bottom bar, bottom line, then you can judge that difference to be statistically meaningful. Real meaning, of course, comes from the size of the bars, and you can see that some of those bars are very high. Most of them are higher than we would expect to see for most conditions, even though we're aware of inequalities in health generally. So a difference of 2 is a very, very large difference. There are 2 groups here where the difference is not statistically significant. One is white other women, and the other is white Chinese women. For every single other group, the risk is raised.
And particularly so for male black African.
Male black Africans is an incredibly high rate, but the rate for male Bangladeshi, well, anything that's at or approaching 2 is incredibly high. Even ones that are 1.5, in pre-COVID research, we would have considered to be very meaningful.
Thank you. Yes, thank you. We can take that down, please. What do the studies that you have been able to access tell us about the risk of infection rather than the risk of mortality?
So the studies on risk of infection, because of the nature of the science that was being carried out, were not really published until wave 2 of the pandemic, but they did cover wave 1 of the pandemic. And they were studies that were basically sending people test kits and then receiving them back and analysing them. And they showed only for very broad ethnic groups. They didn't have big enough samples to split them down in the way that ONS did in that analysis. So it was white versus Asian versus black versus mixed versus other. And they showed higher rates of infection for the non-white groups compared with the white group.
Thank you. And then at paragraph 37 of your report, you say a crucial question then is how far this increased risk of infection during the COVID-19 pandemic led to the increased risk of mortality experienced by ethnic minority people, or whether other factors were also present. And what did you find in relation to that question?
So the existing research evidence makes it very difficult to interpret the answers to that question. So what we see are higher rates of infection, and we see higher rates of mortality. They sort of mirror each other, but it's very hard to make the translation because we don't see the same people through the pathway from pre-infection to infection to illness to admission to hospital to potential mortality. So we don't have that pathway clearly laid out. But it's clear that increased rates of infection played an important role. But it's also quite probable that other factors were also. So increased vulnerability post-infection also played a role, and we also argue that there are issues around treatment that also may be important as well.
Yes, thank you. Could we display, please, at page 11 of your joint report and highlight table 1.1, the top of the page? Thank you very much. This shows ethnic difference in risk of adverse COVID-19 outcomes. So what do we see here, Professor?
Yeah, so this is from one of the studies that did testing and then followed people through the various stages that follow testing. A large sample done over wave 1 of the pandemic and contains those relatively broad ethnic groups that I described earlier in comparison with a white group. And what you can see is a higher risk of testing positive for SARS-CoV-2.
Yes.
A higher risk for a hospital-related admission to hospital, and then a higher risk for the escalation of treatment into ICU, and a higher risk for mortality. So it shows a pattern where the risk is present at each stage.
Yes.
Unfortunately, as I said, we don't have the same people tracked across these different stages, so we can't unpick what's happening at each stage.
Thank you. We can take that down. So moving to your conclusions in relation to this section of your report and paragraph 50, you say that as for the evidence presented on inequalities in risk of infection, a substantial portion of ethnic inequalities in risk of COVID-related mortality is explained by ethnic differences in geographical location and economic, demographic and pre-existing health factors. And in summary, the evidence on ethnic inequalities in risk of infection and mortality strongly suggests that both are driven by geography, so the greater likelihood of ethnic minority people living in urban and deprived locations, socio-economic inequalities and occupational segregation. And in relation to occupations, Black African and Black Caribbean workers are more likely to be employed in key worker roles, and more specifically, particular occupations had a high risk of mortality, including social care workers, security personnel, sales and retail assistants, bus and coach drivers, and chefs. Is that right?
Yeah, so that's all right, though I slightly misused the word explanation. As you read it out, I identified that. This is statistical explanation.
Yes.
And then it moves on to some of the detail behind that. But it's important to remember that those inequalities in where people live, levels of deprivation, types of roles are driven by a whole host of additional factors related to ethnicity, race and racism.
Yes, thank you very much. Is it also right that ethnic minority women were overrepresented in, for instance, social care work and were 3 times more likely to be in precarious and insecure work?
Yes.
Yes, and the inquiry has heard some evidence about that in this morning's session. Yes, thank you. In fact, just before we leave this section, could we display figure 3 at page 18, please? Because I just want to ask you, Professor Nasru, about the ethnic differences in fair or poor self-reported health by age. And this is based on findings from the 2011 census, which I think was also influential in the ONS figures which they were able to produce. It was based on this census. Is that right?
Yeah, so the 2011 census is the data point that the ONS linked to, because the 2021 census obviously had not occurred at that point.
Yeah. And what do we see here in terms of ages?
So the height of the line shows the proportion of the population who say that they have fair or poor self-rated health, which is a good indicator of people's quality of health. And across the bottom of the chart, you can see age groups. And as you go from younger to older, inevitably a higher proportion of people saying that their health is not good. What's important in this chart is the ways in which the lines diverge across age groups. And so when you get to 40 to 49, the lines begin to meaningfully diverge from each other.
Yes.
And then that divergence increases over time. What you see horizontally at the 20% mark, rather coincidentally, 20% of white English people said that their at the age 80 to 89 said that their health was fair or poor. And if you follow that line backward, you can see the age group at which the different ethnic groups cross that line. And so the authors of this report, which include Laia and myself, would argue that this represents premature biological aging in ethnic minority groups, which reflects a life course of exposure to hazard.
Thank you. Yes, thank you very much. Could we take that down, please? Professor Beckeres, I'm going to come to you now to discuss physical health, please. And in particular, did you find that several studies have documented a number of potential complications relating to COVID-19 infection?
Yes, so we found that people who were hospitalized or had COVID infection were more likely to have renal complications and complications around cardiovascular disease. But also for women, pregnant women who were infected with COVID, with the SARS-CoV-2 virus, were twice as likely to deliver a baby that was exposed to death, that baby, compared to women who were not infected with COVID.
Thank you. Did you find that in hospitalised patients with COVID-19, South Asian and Black ethnic groups had higher risk of cardiovascular and renal complications compared to white patients?
Yes.
And that South Asian patients were almost twice as likely to experience cardiac arrest and almost 50% more likely to experience cardiac ischemia rather than white patients.
Yeah, and this relates to pre-existing conditions
Yes.
that around high blood pressure, diabetes, stroke, and other cardiovascular disease.
Yes, thank you. In terms of long-term implications of these COVID-19 related complications, were those more severe in ethnic minority people?
Yes, and particularly if left untreated, these renal complications and ischemic heart disease leads to death. And so the complications, long-term complications are severe.
Yes, thank you. And at paragraph 128, you tell us that long COVID has become an important public issue in the UK, and that Black, mixed and other ethnic groups have experienced increased risk of reporting long COVID symptoms 12 weeks or more after infection.
That's right. Yeah.
Do you agree that protective isolation for shielding households is harder in multi-generational or crowded homes, common in some minority communities?
Yes, absolutely. And as James suggested, evidence shows that people from minoritized ethnic groups were more likely to live in overcrowded and multi-generational households, which led to difficulties in shielding.
Yes, and that exposed the risk for those communities.
Right.
And did that also, is that also reflected in an increase in mental health impact?
Well, difficulties in shielding and protecting oneself from infection will have led to increased anxiety and stress and mental health complications, yes.
Thank you. At paragraph 132, you say, as described in general terms in the Mental Health Systematic Evidence Review, the pandemic and, in particular, non-pharmaceutical interventions implemented to control the spread of infection, including lockdowns, social distancing, and the closure of communal and social spaces, resulted in severe implications for adult mental health. And for ethnic minority groups, this was compounded by increased stress and anxiety about higher risk of infection for themselves and loved ones, increased financial insecurity, and higher rates of bereavement due to increased mortality rates. Is that right? Finally, on this topic, I'll just look briefly at 3 physical health conditions that may have led to a worsening of experience during the pandemic. Cardiovascular and renal complications we've already looked at, and pregnancy. I think you've already given us some evidence about that. And finally, palliative care. Did you find studies reporting an increased inequity in palliative care, with ethnic minority patients being referred later for palliative care than white patients?
Yeah, so ethnic minority patients were referred up to 4 days later than white patients, but there were also difficulties around providing translating services for people in palliative care, but also being able to communicate with family members.
Thank you very much. The Migrants' Right Consortium have provided evidence to the inquiry of the significant mental health challenges faced by migrant communities during the pandemic. Unfamiliar social structures, financial insecurity, travel restrictions, pre-existing conditions, and trauma arising from distressing circumstances which led them to be in the UK, and barriers in accessing mental health support are issues which they have raised, which seem to chime with the evidence that you have found in your research. Is that right?
That's right.
Yes. And this was a subject that was discussed at the Justice Roundtable event. Could we put up, please, the Justice Roundtable report, which is at INQ 000 656 301, page 39. Thank you very much. And let's just have a look at what was discussed and then contained within the report. Mental health and well-being of migrants and asylum seekers. The representative for Project 17, who work to end destitution among migrant families with no recourse to public funds, described how the pandemic meant migrants and asylum seekers did not have access to their usual support networks, such as libraries for warmth, using internet facilities at food venues, or sharing food with friends, all of which affected their mental health. They also noted that some migrants lacked access to nearby outdoor spaces for fresh air and exercise during the pandemic, negatively impacting both their mental and physical health. We can then see a quote from Project 17. Clients were interrogated for being on the park bench because they had no garden. They were trapped in their bedrooms then. The report goes on to say, there was less support available for migrants and asylum seekers during the pandemic, according to the representatives. This included mental health support and a general lack of support available in their own language, which you've made reference to. Representatives said that this had a negative impact on well-being. In particular, Project 17 found that the lack of mental health support available during the pandemic exacerbated migrants' fears that the government would not provide assistance for them or their families. Bail for Immigration detainees similarly noted that the pandemic and the treatment of migrants during this time fostered a sense that they were not important, reducing their sense of belonging and damaging their mental health. And finally, I can't remember any additional mental health support during the pandemic for people to reach their communities, families and friends. Yes, thank you very much. We can take that down now. What did you find, Professor Beckerez, in terms of levels of physical activity during the pandemic?
Well, minoritized ethnic groups were less likely to engage in physical activity, and the reason for this is they are more likely, as James mentioned, to live in deprived areas with reduced access to green space, but they also were more likely to live in houses, in flats without a garden, and so their access to physical activity is severely limited.
Thank you. Healthcare services next, please. You tell us at paragraph 144, policies implemented to contain the spread of the virus, including lockdown and social distancing, led to changes in hospital and general practitioner care. Prioritisation of COVID-19 reduced availability of treatment and medical advice for non-COVID-19 care, resulting in healthcare disruptions and unmet needs. What did you find in terms of ethnic minority people, and in particular, people from black ethnic groups?
Well, the more minoritized ethnic groups, and in particularly people from black ethnic groups, were more likely to experience disruptions in healthcare, in particular with GP appointments and scheduled hospital appointments.
Yes, thank you. And in the first 8 to 10 months of the COVID-19 pandemic, what were those disruptions particularly acute?
Yes, that's right.
Thank you. Moving to employment and economic impacts, please, Professor Nasru. You tell us at paragraph 148 that the occupational profile of ethnic minority workers, particularly those in Bangladeshi, Pakistani, Black African and Black Caribbean groups, made them more vulnerable to the harms resulting from lockdown measures. Why was that?
This relates to the employment sectors that those particular ethnic minority groups worked in. So they were more likely to work in shutdown sectors, more likely to be in precarious employment, by which I mean 0 hours, part-time type contracts without continuity. They're more likely to, it varies across the different ethnic groups, but also
yes.
more likely to be self-employed, working as sole traders, so in very small businesses that were then vulnerable. A large proportion of ethnic minority workers also work in industries which rely on tips as part of their salary.
Yes.
And of course, tips aren't counted when we think of furlough schemes. And importantly, for various reasons, more likely to be in households where only one of the adults was earning money. Which then meant that particular adult and their employment was crucial for the economic well-being of the household.
Thank you. In terms of impact on ethnic inequalities during the pandemic and the amplification of those inequalities, at paragraph 158, you say the coronavirus job retention scheme helped compensate for the loss of earnings of employed workers who were furloughed. But of course, what you've just told us about the types of employment that many ethnic minority people were employed by may not have qualified for the coronavirus job retention scheme.
Yeah, so if you're on a precarious 0 hours type, part-time type contract, then it's very hard for your employer to include you in the list of people who are furloughed, even if they are motivated to do so. And if you rely on tips for 20% of your salary, that's not counted.
Yeah.
So on.
Thank you. At paragraph 163, you tell us about a local study based in Bradford that you found from 2023, which examined differences in the financial circumstances of Pakistani and white British families during the COVID-19 pandemic. What did that show?
I'm sorry, you're going to have to remind me.
No problem. I can remind you that it showed that early in the pandemic, in both April 2020 and June 2020, Pakistani families were almost 3 times as likely to report being financially insecure compared with white British families, and were slower to recover from financial insecurity than white British families, who, unlike their Pakistani counterparts, had returned to pre-pandemic levels of financial insecurity by October to December 2020. Is that a study which was surprising to you or not?
No, so it wasn't surprising. It was a local study, but a very robust study.
Yes.
The crucial things here is that those findings point to the precarity of employment and recovery post-pandemic from employment. Also, very important is the amount of economic resources that people can rely on when they don't have income. So yes. how big your savings pot is. And again, there are variation across ethnic groups in terms of how big that savings pot is and how long that will last for, with ethnic minority groups, except for Indian people, having smaller savings pots than white people.
Thank you. At paragraph 168, you also reflect upon a study of migrant Polish key workers in precarious employment that noted that during the pandemic, such workers faced redundancy, pay cuts, reduced hours, and unpaid sick leave, and with the implication that employers used their precarious employment status to avoid providing them with appropriate financial support. The risk of unpaid sick leave, you say, or job loss, was particularly problematic from a public health point of view because it incentivised employees not to take time off when they may have had symptoms suggestive of an infection. And again, was that something which was surprising or not to you?
So it was not surprising again. So this study was a focus study, but it echoed findings in more anecdotal pieces of evidence
Yes.
from across the sector, which pointed to the ways in which precarious employment led to both greater individual risk, but then in order to compensate for that risk, people who were ill continued to work. It's been documented previously in terms
Yes.
of influenza pandemics as well. And so ethnic minority people continue to work, exposing both themselves and others to the harms of COVID-19.
Thank you. Finally, on this topic, we've received a TUC report from 2022 suggesting that structural racism traps Black, Asian and minority ethnic workers in lower paid and insecure work. In terms of access to PPE for Black, Asian and minority ethnic workers, do you consider that the disproportionate number of ethnic minority workers in precarious work and not being given access to effective PPE may have had a feature in the level of infection?
So ethnic minority workers not in precarious work were less able to access PPE. So they had lower rates of access to PPE, even though they were in secure work.
Right.
And then in precarious work, of course, those risks are likely to have been amplified. I don't have evidence outside of the TUC report on how those risks were amplified, but certainly it was noted in that report.
Thank you. And in terms of unequal access to the furlough scheme, how can access to any furlough scheme used in a future pandemic be improved for Black, Asian and minority ethnic workers?
Yeah. So there are clear risks that a furlough scheme will be exploited by bad actors. But nevertheless, if we're to protect the most vulnerable, then we have to be aware of those risks and take some of them with precaution. In this particular case, people with precarious employment should have access to furlough schemes. They did not straightforwardly in the pandemic. People on 0 hours contracts, again, should be able to have access to those schemes. Those schemes should incorporate more informal sources of income. And importantly also, people who are working in small businesses with no resources, with scepticism about whether they would actually get the equivalent in terms of a furlough scheme, should be, their access to those schemes should be eased.
Thank you. Professor Beckerez, I'm going to come to you now to discuss housing. And we'll look at 5 areas, if we may. The first, housing quality. You say at paragraph 171 that ethnic inequalities in housing conditions during the pandemic were stark across multiple domains, and that ethnic minority households experienced significantly higher rates of damp conditions and overcrowding, which we've already discussed, than white British households. Is that right?
That's right.
Thank you. Is there sufficient data in terms of this area?
Yes, so we know in England, for example, that people from Black Caribbean, Bangladeshi, Pakistani ethnic groups are more likely than white people to live in houses with damp. In Scotland and Wales, we don't have the same level of evidence, but we know that minoritized ethnic groups are more likely to live in the private rented sector, which is associated with poorer housing quality.
Thank you. The second topic is overcrowding, which we've already dealt with. The third topic, multi-generational households. Some ethnic minority households, in particular Pakistani and Bangladeshi households, are more likely than white households to have older people over 65 living with children. Is that right?
That's right, and also Roma households.
Right. And multi-generational households experienced an increased likelihood of having a clinically vulnerable person cohabiting with adults who were key workers. So lots of risk involved there in that particular circumstance.
Yes, both with adults who are key workers, but also with children who are attending school.
Thank you. The fourth topic, area-level deprivation, which we've already covered, and access to outdoor and green spaces is the fifth area. You've touched upon this, but has there been ONS analysis conducted which showed that 12% of households in England and Wales and 13% in Scotland had no access to a private or shared garden during the lockdown, the first
yes,
lockdown?
And this was more likely for minoritized ethnic groups. I think they were 4 times less likely than white people to have access to green space.
Thank you. Next topic, social networks and social inclusion, please, Professor Beckerez. I'll remain with you and discuss, please, general findings, first of all. Paragraph 193, you say the COVID-19 pandemic significantly impacted social cohesion and community relationships among ethnic minority groups in the UK, with notable variations across individual ethnic groups. Is that right?
That's right.
All right. Secondly, social cohesion and belonging. You say that in England, this is paragraph 194, studies that compare pandemic levels of neighbourhood-level social cohesion to those of pre-pandemic times find an overall trend for reduced levels of cohesion. Is that right?
That's right. So this is a summary measure that captures how well people get along with people in their neighborhood, how much they trust their neighbors, and whether they would help their neighbors or whether they would receive help from neighbors.
And you did note that the decline in levels of social cohesion was particularly high in the most deprived communities when compared to the least deprived, and among people from black ethnic groups who were more likely to experience negative changes in social cohesion.
Yes, and this is something that James and I had done some work pre-pandemic, and we had found that areas of high deprivation are areas of lower social cohesion, and this was exacerbated in the pandemic.
Thank you. And finally, on this topic, loneliness, at paragraph 197, you tell us that higher levels of loneliness amongst ethnic minority groups compared to white British people have been reported by studies that combine all ethnic minority groups into one non-white category.
That's right.
And that the evidence is more nuanced when individual ethnic minority groups are examined independently.
Yeah, so we conducted a study called Events, which captured ethnicity in very fine-grained categories. And when we look at ethnicity across subgroup categories, we find that some minoritized ethnic groups did report higher levels of loneliness,
Yes.
in particularly white Irish, mixed other, and Black Caribbean groups, whereas others didn't.
Not so much, thank you. And the final topic before we come to lessons learned is policing and criminal justice. And I'll remain with you, please, Professor Beckerez. In terms of general findings, at paragraph 199, you tell us that unequal treatment by the police and law enforcement agencies towards ethnic minority people was exacerbated during the pandemic. How so?
Well, minoritized ethnic groups were more likely to be given fixed penalty notices, which
Yes.
were on-the-spot fines given by the police around violations of lockdown rules. They were also more likely than white British people, and in Scotland and Wales as well, to be stopped and searched by the police. But there was also racialized enforcement in Black Lives Matter protests.
Thank you. And at paragraph 207, you tell us that the interaction between increased policing, anticipation of police violence, and pandemic-related fear and anxiety from risk of transmission, infection, and mortality from the virus could be associated with the documented worsening of mental health. For example, you say that analysis of the Evidence for Equality National Survey, EVANS study, showed that when compared to white British people, some ethnic minority groups were more likely to experience anxiety than white British people.
That's right. And it's important to say that the inequities in police enforcement were really stark. So, for example, in some areas of England, the minoritized ethnic groups, particularly young men, were 7 times more likely to be given fixed penalty notices than young white men of the same age group. And so these are really stark inequities. And the fear of being given a fixed penalty notice or being stopped and searched has been, or fear of police enforcement has been associated with poor mental health. So these associations, exist.
Thank you. I'm going to summarise your evidence on lessons learned and then come to you for any additional comments that you may wish to add. Firstly, there needs to be a monitoring of the spread of the pandemic to identify any inequalities in infection and mortality, a control of the spread of a pandemic and reduce impact on health and mortality. This includes ensuring healthcare systems avoid exacerbating ethnic inequalities in health and that clear systems are developed on how to self-isolate for people living in multi-generational accommodation. Consider the impact that non-pharmaceutical interventions to control the pandemic have on physical and mental health. Access digital exclusion as a factor affecting access to essential services during emergencies. To review the financial support schemes put in place during the pandemic in terms of policing and criminal justice. Any policies developed should consider possible disproportionate impacts on ethnic minority groups. And then at paragraph 240, you say this: Ultimately, we suggest that a focus on institutional racism, working in partnership with both public and private institutions, must be at the centre of approaches to combat all forms of racism. We recommend this focus on institutions because it is practices within institutions, as provider services and as employers, that can be developed to address social and economic inequalities, that institutions can provide anti-racist leadership and advocacy, and the concrete nature of institutions makes them the appropriate location of action rather than the more nebulous natures of social structures and individual action. Professor Beckeres, is there anything that you would like to add to that?
Well, I think the focus on racism is crucial, but an understanding of how racism had structured pre-existing inequities that we describe in Module 2 and how it structured all the impacts that we have described. And without this focus on racism and how it structures health, social, economic, and political vulnerability, then there is no lessons to be learned. Yeah.
Thank you. Professor Nasru.
Yes, thank you. The focus on institutional racism in that paragraph reflects a broader analysis, which is briefly presented in the paper, on the ways in which racism affects people's lives. And so we often think of racism as the insult or the ignoring or the police surveillance or whatever it might be, but there are a whole set of other issues going on that lead to disadvantage for ethnic minority people. We provide, as I say, a brief summary of that analysis. Institutions are crucial because they become vehicles for change, and that's why we identify institutions as crucial here. They become vehicles for change. Also important in the context of the pandemic is to think about the ways in which health institutions operate, by which I mean the medical technologies, the pharmaceutical industries, as well as things like the NHS and social care. And one of the things we haven't touched on is the ways in which medical technology was not fit for purpose during the pandemic, and how technologies were designed using white people as the template. And so this relates to both pulse oximetry and to PPE.
Yes, thank you. I hesitate to interrupt you. The reason that we haven't dwelt on that today, although it is in your report, is that my lady has heard evidence in Module 3 about those matters, and I know that is going to be covered there, but thank you very much for mentioning that. My lady, that concludes my questioning. My lady has given permission for questions to be asked of Professors Beckeres and Nasru from the Migrants' Rights Consortium and also the Trades Union Congress.
Thank you very much. Ms. Veeraratne, I think you're first. Thank you.
Thank you. Good afternoon, Professors. I act for the Migrants' Rights Consortium. And a key concern for us in this group are those migrants subject to immigration control and excluded from essential welfare services, subject to NHS charging and data sharing, and in precarious employment. In your report, your joint report, at paragraphs 40 to 71, you consider the factors leading to increased risk of infection for ethnic minority people. What you identify 5 areas for analysis, and I want to ask you both about immigration status in addition. So would you agree that immigration laws and policies that exclude people from the mainstream welfare system and create barriers to accessing healthcare, such as charging and data sharing, would be a further factor leading to increased risk of infection for those ethnic minority people who are also migrants?
Yes, absolutely. I think it was, in my opinion, it was a mistake to not relax those pieces of legislation and to not to provide firewalls to prevent information being passed across from health agencies to border enforcement agencies.
Professor
Yeah,
Bakaris?
can I add? It extends beyond healthcare because Liberty and Southall Black Sisters had a super complaint that found that police enforcement agencies were sharing immigration information with the Home Office. So I agree with you and James's
Thank you.
comment, but it extends beyond healthcare.
We did hear about the sharing with the police and the immigration earlier today. And Professor, if I might just follow up with this, Professor Nazrou, you said you would get rid of these policies, I think you said. Do you mean the hostile environment policies?
I think the legislation that restricts access to public funds should have been reconsidered during the pandemic. I think that was the point I was trying to make. The hostile environment policy, I think, is a broader issue that extends beyond the pandemic. Personally, I'm sympathetic to your view there.
Thank you so much. And if I do have, just to follow up, just to be perfectly clear, do you also agree then that the risks posed to migrants as a result of these structural barriers or these legislative barriers that you understood to be in existence cannot be described as speculative or based on a reductive and stereotyped understanding of migrants' experience? And I say that because that's a caveat that you apply yourselves at paragraph 41 to the analysis that you provide to the 5 factors you identify in relation to ethnic minority people more generally.
Yes. So in paragraph 41, we're referring to a predetermined list. We then go on to provide evidence for some elements of that list and a lack of evidence for other elements of that list. In the case that you raise, I think the evidence is reasonably clear.
Thank you so much. Thank you both.
Thank you. Ms Peacock.
Good afternoon. I ask questions on behalf of the Trades Union Congress. Professor Nazrou has explained in evidence today that ethnic minority workers, whether in insecure employment or not, were less likely to have access to appropriate PPE. Your report at paragraph 82 states that there were suggestions that more discretionary elements of their employment were relevant to that poorer access. Could you please describe what that means and how discretionary elements of work may have impacted upon access to PPE for ethnic minority workers?
If you just give me a moment to glance over the paragraph again.
I'm grateful. It's 82 on page 21.
Yeah. So you can imagine a range of discretionary elements of employment that might be relevant here, how a line manager interacts with you, the location in which you're working, whether the PPE fits appropriately, and so on. In this case, I think I'm referring to people being in more positive employment contexts, being more likely to say that they have received adequate PPE. And so you can think of the whole range of things that might be a more positive employment context. In this case, it's really around the ways in which their race and ethnicity is perceived and acted upon in the environment.
I'm grateful. Those are my questions.
Thank you, Ms Peacock.
My lady, is that a convenient time for us to take our afternoon break?
Certainly, just so people understand, because it took me a while to follow. We've taken the questions before we get to the individual
Yes.
report for the 2 experts, right? Fortunately, someone told me in a message.
No, I'm sorry.
Thank you. No, that's
I should have explained that perhaps at the beginning, my lady. I'm sorry that took you unawares.
No, that's absolutely fine. Very well, I shall return at past.
Thank you very much. My lady, can you see and hear me?
I can, thank you very much.
Thank you very much. We're now going to turn to Professor Becker's report and evidence on inequalities experienced by LGBTQ plus groups. So, Professor, you should have in front of you your copy of the report. For our reference, it's INQ 000657973. Can you confirm that this is your expert report that you have provided for the purposes of Module 10?
It is.
And that the facts stated within it are true to the best of your knowledge and belief?
They are.
And that any opinions that you have stated in the report represent your true and complete professional opinions?
Yes.
When you were last giving evidence in Module 2, you described those who identify within the term LGBTQ+. Could you remind us, please, of what that umbrella term encompasses?
Yeah, so this is a very broad umbrella term that captures people who self-identify with a sexual orientation other than heterosexual and or a gender identity that does not align with the sex they were assigned at birth. And the letters stand for lesbian, gay, bisexual, trans, queer, and the plus captures people who identify with a label other than these categories or no label at all.
Thank you. You describe within your report general patterns and trends experienced by LGBTQ+ people, but you say that there may be some variation in outcomes within each acronym.
Right, so this is a very diverse
Yes.
group, both within and between categories of sexual orientation and or gender identity. There are also differences across ethnicity and migration, social class, age, all of which will be represented in differences in health, social and economic outcomes.
Thank you. Did you find different approaches to gender across the 4 nations of the UK?
Well, the 4 nations of the UK, England, Scotland, and Wales have perhaps more similar approaches to gender identity or protections around gender identity than Northern Ireland.
Yes.
Yeah.
And does that in any way lead to difficulties identifying relevant research, for instance, in Northern Ireland?
Well, the data in Northern Ireland are more limited,
Yeah.
for both for gender identity, certainly, but also for sexual orientation.
Thank you. I'd like to just have a look, please, at the beginning of your evidence at our evidence review, which is at INQ 000659787 and page 73, which confirms the paucity of data. And we can see that within gaps in the evidence, there is reference at the second bullet point down to sexual and gender minorities. Transgender and gender diverse individuals are notably under-examined due to data limitations. For example, the lack of specific questions regarding gender identity in large population-based surveys, small population samples, recording studies to binary gender. And in addition, sexual minorities are often aggregated, masking potential differences in mental health outcomes within these diverse populations. Does that mirror what you found in your research in terms of a lack of data?
Yes, certainly lack of data and data gaps are one of the crucial limitations of how policies were able to address or not address LGBTQ inequities, because there was no evidence to demonstrate either inequities in infection and mortality, but also in other outcomes related to the pandemic.
Thank you. We can take that down, please. And at paragraph 12 in your report, you say that despite pre-pandemic evidence documenting that LGBTQ+ people had increased exposure to social and economic risk factors for COVID-19 infection and mortality compared to heterosexual and or cisgender populations, the UK lacks comprehensive data on COVID-19 infection and mortality outcomes for LGBTQ+ populations, and that existing evidence confirms that people with HIV, disproportionately affecting gay men and trans women, faced 2 to 3 times higher COVID-19 mortality compared with people without HIV. Is that right?
Yeah, so to date, we
Yes.
don't have any evidence on inequities experienced by LGBTQ people on infection from COVID or mortality from COVID. So 5 years later, we don't have any information on this. We can hypothesize based on other indications like increased rates of mortality of people living with HIV, that they may have been increased rates of mortality. also because of pre-existing health conditions that you mentioned and that I described in the report for Module 2. But it's important to say that we still do not have any information on this.
Thank you. At paragraph 30 in your report, you list various experiences of those that come within the LGBTQ plus umbrella, populations experiencing several risk factors that put them at increased risk of infection, poorer prognosis, and indeed mortality. And I'll just run through a few of those, if I may. You tell us this: lesbian women were more likely to be key workers compared to heterosexual women. And in particular, trans women were overrepresented in sex work. Lesbian and bisexual women also had higher rates of obesity and asthma. Gay men and bisexual people were more likely to smoke than heterosexual people. Trans people were more likely to be disabled and to have chronic health conditions. LGBTQ plus people were also overrepresented among patients with certain types of cancer, and all of these factors have been documented to be associated with increased risk of infection and or mortality from COVID-19. Is that right?
Yeah, so because we don't know the actual prevalence rates of infection or mortality, we have to assume from pre-existing information around occupation risk and how that relates to risk of infection, but also pre-existing health conditions that now we know are associated with poorer prognosis from COVID. So we can hypothesize that there were higher infection rates and higher mortality rates.
Thank you. Turning to physical health, health behaviours and access to health and social care services, and covering 6 brief topics, please. First, pre-existing health and social inequalities experienced by LGBTQ plus groups. You say at paragraphs 34 and 35 that these people are less likely to access key health services compared to non-LGBTQ plus people. Why is that? What's been found historically about that position, please?
Well, historically, LGBTQ people are more likely to be discriminated and stigmatized against in mainstream healthcare services. So in order to avoid discrimination, they are less likely to seek these services. When they access services, they are more likely to be less satisfied and to receive lower quality of care. And so LGBTQ people are therefore more likely to seek services provided by LGBTQ third sector organizations, which are inclusive of LGBTQ care.
And so, moving to what happened during the pandemic, we have received a report from the LGBT Foundation entitled Hidden Figures, the Impact of the COVID-19 Pandemic on LGBT Communities in the UK, May 2020. Could we display this, please? It's INQ 000217403. Let's have a look at the first page. There we see the title, and it's the 3rd edition of this particular paper. And can we go, please, to page 24? We can see here that, according to this report, at a time when our ability to access healthcare and the way we access healthcare has substantially changed, those who faced barriers prior to the crisis may be particularly affected. The survey revealed that respondents had been affected by changes to healthcare, with Black and Asian minority ethnic people, disabled people, and people aged 50 plus more likely to be affected. Access to healthcare for trans and non-binary communities is covered in the next section. But looking at some of these percentages, 16% of respondents had been unable to access healthcare for non-COVID related issues, rising to 22% of Black, Asian, minority ethnic LGBT people, 26% of disabled LGBT people, and 18% of LGBT people who were aged 50 plus. 34% of people had had a medical appointment cancelled, and that rose to 39% of Black, Asian, minority ethnic LGBT people, 42% of disabled LGBT people, and 42% of LGBT people aged 50 plus. 23% of respondents said that they were unable to access medication or were worried that they might not be able to access medication, including 37% of Black, Asian, minority ethnic people, 36% of disabled LGBT people and 21% of LGBT people aged 50 plus. And 27% of people who said that there was medication that they couldn't access or were worried that they wouldn't be able to access mentioned access to antidepressants or other medication to help manage poor mental health. And do those figures reflect your experience from your research of how this particular aspect of access to health was restricted during the pandemic?
Yes, and it's important to add here that access to gender-affirming care was severely disrupted, but as was access to HIV preventative medication.
Thank you. We'll come to that in a moment, because the third topic under this heading is sexual health clinics and testing. Were there concerns among sexual health clinics that after lockdown measures were lifted, they would have difficulties coping with the increased demand? And did research show that in certain drop-in services, that in fact did come to pass, and that they have not yet caught up with the long waiting times that were generated during the pandemic when services weren't available?
Yeah, so many of the services were moved to online provision, but also some services were shut down. And research suggests that services have not yet caught up.
Thank you. Next, gender identity clinics. You tell us at paragraphs 47 and 48 of your report that the LGBT Foundation received multiple reports from trans and non-binary people who had been denied access to prescribed and scheduled hormone injections, with some being told that these were non-essential, and that there was also significant financial impact from funding private treatment and physical impacts from continued chest binding.
Yes, some people who were receiving gender-affirming care had their services disrupted, but also people who were on the waiting list to receive gender-affirming care were told that the waiting lists were frozen or discontinued. And so this not only, as you say, led to impacts on physical health from chest binding, but also led to important worsening of mental health.
Thank you. Health behaviours, the fifth subtopic here, access to food and medicine. At paragraph 51, you tell us of an online study of 1,540 people conducted between April and May of 2020 in the northwest of England, which found that LGBTQ plus people were twice as likely to report being unable to access sufficient food and required medication compared to non-LGBTQ plus people. Is that right?
That's right.
And finally, physical health. Was there an analysis of the nationally representative Millennium Cohort study, which found that sexual minority young adults had poorer general health than heterosexual young adults?
Yes, so this is a study I conducted with my colleague Dylan Neal, and we found that sexual minority young adults were 4 times more likely to report poorer self-rated health compared to straight young adults of the same age and similar socioeconomic conditions.
Thank you. Well, turning to economic conditions and finances, you note an increase in financial inequities, and at paragraph 54, you confirm that trans women were overrepresented in sex work, an industry that was severely disrupted by the pandemic, that gay and lesbian people were more likely than heterosexual people to report being a key worker, which included individuals who worked in health and social care, education and childcare, key public services, local and national government, food services, public safety and national security, transportation, utilities, communications and financial services. So across the key worker spectrum.
Yeah, well, this is the definition in the survey. Yes.
Yeah. And so those people who were assessed as being key workers and who continued to work throughout the pandemic were themselves exposed to a greater risk. Is that right?
That's right. And so there were financial inequities in financial stability pre-pandemic, but as you mentioned here, trans women were more likely to overrepresented in sex work, which was severely disrupted. but it's also an industry that had increased risk of infection, as did key workers.
Thank you. Could we put back up, please, the Hidden Figures report, which is INQ 000217403. Thank you very much. And at page 22, we can see that there is reference to lower socio-economic groups and financial impact. The crisis is having a more profound effect on people in lower socio-economic groups, with lower paid people more likely to be hit by the economic consequences of the crisis. Although there is a lack of data on poverty and deprivation levels in LGBT communities, the research that exists suggests that groups within LGBT communities are more likely to be worse off financially. Analysis of the UK household longitudinal study found that gay and bisexual men experience greater material disadvantage compared to heterosexual men, while bisexual women experience greater material disadvantage compared to heterosexual women. Thank you. The National LGBT Survey 2018 found that employment rates are considerably lower for trans and non-binary people. 63% of trans and non-binary respondents had a job in the 12 months preceding the survey, falling to 56% of Black, Asian, minority ethnic trans people. This compares to an employment rate of 75% at the time. Additionally, 60% of trans people stated that they earned less than £20,000 per year. And of our survey respondents, 9% said that the COVID-19 crisis has meant that they have had to claim financial support from the government that they wouldn't usually claim. 12% stated that they needed financial support but had not received any. This includes 11% of Black, Asian, minority ethnic LGBT people, 19% of disabled LGBT people, 21% of trans people and 16% of non-binary people. And there are then two comments from survey respondents. Not eligible for anything, I'm on my own, and applied for many things but have received nothing at all. 11% would like assistance accessing financial support provided by the government. Again, does that reflect your understanding of the particular difficulties that LGBTQ plus people were having in relation to the financial impact of the pandemic?
Yeah, and it's also important to note that because of disruption in gender-affirming care, some people had to access this privately. And because of disruption to mental health support, people had to access this privately, and same for fertility services that were disrupted. And so this incurred further financial difficulty.
Thank you very much. We can take that down, please. Moving to housing, and three brief topics, please. First is living in unsupported environments. At paragraph 69, you say a large proportion of LGBTQ plus people, and in particular young and trans people, experienced lockdown in housing environments where family members or flatmates were not supportive of their sexuality or gender identity.
Yes, so people were experiencing lockdown in hostile living conditions.
Yes.
Where people were either threatening or belittling. So many people had to not be themselves in these circumstances, to the extent that a charity, AKT, which is a national charity that supports young people experiencing or at risk of homelessness, cautioned young people against coming out due to the threatening environments they were experiencing.
Thank you. Second topic, domestic abuse. You refer to a lack of mainstream recognition of domestic abuse occurring outside of opposite-sex relationships and the way that this increases barriers for LGBTQ plus people seeking support. The public messaging and domestic abuse services, should that be clearer in terms of what is likely to happen or who can become victims of domestic abuse during a pandemic?
Yes, during the pandemic and outside pandemic
outside
times.
of the pandemic.
So there is perhaps the common picture of what domestic abuse looks like, which excludes people not in heterosexual relationships or not in cisgender relationships. And this is important because this may lead to hidden instances of domestic abuse. And so, the messaging needs to be reframed, not only in relation to partnerships, romantic or otherwise partnerships, but also in relation to family members abusing LGBTQ people.
Thank you. In June 2020, the Mayor's Office for Policing and Crime commissioned a 4-bed specialist LGBTQ+ domestic abuse accommodation project led by the Outside Project, directly responsible to these needs and representing one of the very few examples of specialist provision addressing critical gaps in safe accommodation and protection from COVID-19. Was there a lack of suitable LGBTQ+ refuge and temporary accommodation placements for people fleeing abuse?
Yes, absolutely. And because I think there was an Everyone In campaign, which housed people experiencing homelessness, but the same dangers or harms that were experienced in households, so for example, threats and belittlement because of people's sexual orientation and gender identity, there was a fear that this would also take place in mainstream circumstances or shelters. And so there was a lack of these LGBT inclusive provisions, which the Outside Project addressed. Yeah.
Thank you. Social networks, support and social inclusion. You tell us at paragraph 91 that social networks and support for LGBTQ+ people may not include people they live with and may be more geographically dispersed. So LGBTQ people, and in particular, you say older gay men, are more likely to live on their own and therefore experience an increased level of social isolation and loneliness throughout the pandemic.
Yeah, and I think there's a life course approach here because young LGBTQ people are also less likely to be close to family members as compared to heterosexual young people. They are less likely to be out to a family member as compared to being out to a friend. And so in the early life course, this occurs. And then in later life course, LGBTQ people as social networks are more likely to be geographically dispersed. They are more likely to experience social isolation, as you mentioned with gay men, but they are also less likely to have the digital skills needed to engage in online support.
Thank you. Discrimination and harassment. Paragraph 105, you tell us that personal safety was a major concern for LGBTQ+ people during the pandemic, both inside the house, as we've discussed, and in public settings. Increased harassment due to being LGBTQ+ was reported across multiple surveys. A large online survey found that almost half, that's 46%, of the LGBTQ+ people sampled had experienced harassment because of their identity in a public setting during the first year of the pandemic. And you go on to say at paragraph 107 that relatedly, the LGBT Foundation experienced a sharp increase in helpline calls related to discrimination during the pandemic. In late March to early April 2020, they received 4.5 times as many calls and twice the amount of calls about biphobia and transphobia, and a 52% increase related to homophobia compared to the 3 weeks prior. The nature of harassment changed slightly during the pandemic, you tell us, although the most common forms of harassment remained verbal harassment, exclusion from events or activities, and involuntary disclosure of LGBTQ+ identity, and new pandemic-specific forms of discrimination emerged. Is that right?
Yes, so for young people, there was an increase in online bullying, while outside there were discriminations because of the assumption that two people of the same gender are not a couple, and so they might be breaking lockdown rules.
Yes.
But also when work for some people moved online, there was Zoom bombing, that it's called. So people disrupting Zoom events to discriminate and harass LGBTQ people.
Thank you. Mental health and well-being. As a result of insecure housing and homelessness, which we've touched upon, that you tell us is likely to have had an effect on the mental health and well-being of LGBTQ plus people.
Well, insecure housing,
Yes.
living in hostile environments, disruption to gender-affirming care and other healthcare, poor social networks that are more geographically dispersed, so less access to social networks, increased harassment, but also that disregard that LGBTQ people had in the public sphere. So they were supported by the LGBTQ third sector, which was in themselves experiencing strong financial difficulties.
Yeah.
And the fact that there was no discussion around LGBTQ plus issues is also related to poor mental health.
Thank you. And we'll look briefly, please, if we may, at two reports. Back to the Hidden Figures report, first of all, please, and to page 11, which deals with mental health. And we'll just look at the first two paragraphs, please. The COVID-19 crisis is having a profound impact on the general population's mental health and well-being. It is causing significant stress, anxiety, isolation, financial uncertainty and disruption to support services. The profound and lasting impact on mental health is being recognised as the World Health Organization has warned of a global mental health crisis and stated that mental health is a priority to be addressed urgently. This is likely to particularly affect LGBT communities, as there is extensive research to show that LGBT people are more likely to experience poor mental health in general. For example, a 2018 study found that 31% of cis LGB people and 46% of trans people had thought about taking their life in the previous year. In comparison, NHS Digital reports that 1 in 20 adults in the general population had thought about taking their own life in the same time period. So just pausing there, going into the pandemic, we can see that there was considerable concern about the mental health of people that fall into these categories. And what you've just described as being the effects of the pandemic and that the lockdown restrictions would have, I think you would agree, exacerbated the already precarious mental health being suffered by some.
Yes, certainly. So before the pandemic, LGBTQ people were more likely to have higher rates of anxiety, depression than heterosexual and cisgender people, more likely to self-harm and report suicidal ideation, and more likely to attempt suicide than non-LGBTQ people.
Thank you. We can take that down. And in fact, we don't need to display the next report. It's a report from Opening Doors London entitled Only Connect, the impact of COVID-19 on older LGBT plus people, and it's dated November of 2020. I think you've had a look at this report, haven't you, Professor? The headlines of which are that the impact of COVID-19 on the health and well-being of older LGBTQ plus people was a negative one. And there were feelings of loneliness and isolation, as you've already made reference to. It highlighted the importance of socialising and having someone to talk to and support from neighbours and local community. And it also identified practice and policy implications going forwards. So, to lessons learned, please. And towards the end of your report, you confirm in paragraphs 113 to 131, and I summarise, that there is a necessity to ensure public health surveillance bodies, including the ONS, provide equitable data and equitable access to data and linkages that can document and monitor LGBTQ plus health, that there should be a development and maintenance of that data and research infrastructure which is needed to monitor infections and mortality for LGBTQ plus populations going forwards. Just pausing on the issue of data, do you agree that disaggregated data on disability is required across all domains of policy making, not limited to rates of infection and mortality.
Yes, absolutely. But I agree wholeheartedly. But in order to be able to disaggregate across disability, we need really large sample sizes. And at the moment, we have very small sample sizes, which don't allow for disaggregation across sexual orientation or gender identity to begin with. And so at the moment, we have this crucial gap of evidence because of very poor data infrastructure. Very few surveys collect data on sexual orientation, even fewer on gender identity. And when they do, the numbers are so small that they don't allow for robust analysis. In order to be able to disaggregate by disability and other characteristics, we need an oversample, a boosted sample of sexual and gender minorities.
Thank you. And do you agree that where there is a lack of data, this prevents community and representative organisations from demonstrating the need to access funding, and notwithstanding the vital role played by those organisations?
Absolutely, and this is something I mentioned in the report, that there was evidence at the beginning of the pandemic that the third sector could not, didn't have the evidence at the national level required to request support. And so without the data and the evidence, it's very hard to make a case for policies and services. But without data infrastructure, we don't have this data. And I think it's important to say here that all publicly funded studies, like the ONS infection survey, the ZOE study, the COVID-19 social study, that collected data on infection and mortality, none of them included a question on sexual orientation or gender identity. And these are publicly funded studies.
And that needs to change.
Exactly.
And finally, then, you also propose the condemnation of any hate and harassment against LGBTQ plus people, ongoing treatment that should be funded, to ensure that frontline staff delivering health and social care services have received training in LGBTQ plus inclusion, and to support voluntary and community organisations to develop flexible mechanisms to make sure that they can provide ongoing care for the community.
Yes, and if I may add, also
Please.
to increase support for the LGBTQ third sector, which was already experiencing financial difficulties entering the pandemic, and who were many times not able to access the furlough scheme and other financial support schemes, and who were supporting the LGBT community in this event.
Professor Beckeres, thank you very much. My lady, there are no core participant questions for Professor Beckeres, so may I now move to the final report of the day, and it's yours, Professor Nasru. You should have in front of you your report, which for our reference is INQ 000588213 on inequality, later life and ageism. Can you confirm that that is the expert report that you've provided for Module 10?
It is.
And that any facts stated within the report are true to the best of your knowledge and belief?
They are.
And that any opinions you have stated in the report represent your true and complete professional opinion?
They do.
Thank you very much. Your report for Module 10 continues, as with the others, where your M2 report paused. And so this report details the inequalities and vulnerability faced by older people, including those living in care homes or awaiting discharge from hospital into care, and how older people, you say, became victims of the prioritisation of acute hospital services and of patients within acute hospital services. And it covers the impact of the COVID-19 pandemic and of the policies to address the pandemic on levels of loneliness and social isolation, the mental health and well-being of older people, access to health services and physical health, and the economic and employment situation of older people. You say at paragraph 7 of your report that the primary focus of it is on those aged 65 or over, although in places you draw on evidence relating to adults in the 50 and older age bracket. The role of ageism is highlighted in your report. What do you mean by ageism, Professor Nasru?
So ageism has been defined as a set of stereotypes and prejudices attached to older people, which then play out in the ways in which they're treated at an individual level and at a societal level. These stereotypes and prejudices, excuse me, largely focus on declining physical ability, declining cognitive capacity, vulnerability, dependency, a lack of contribution to society, and therefore a devaluing of older people. I just add that the characteristics that are used to devalue older people are those that are more commonly attached to poorer and frailer older people. So
Such as?
Well, poorer and frailer older
Yes.
peoples. And so the experiences are not homogenous across the older population.
Thank you. The evidence from your report, you tell us at paragraph 9, is drawn primarily from England, although places evidence from other countries in the UK as well, in combination with the evidence from England. Is that because of the much greater availability of evidence on inequalities in later life from England?
Yes, so we're very fortunate within England. I would say this because I'm one of the people who's run this study. We have the English Longitudinal Study of Ageing, which has been running for a large number of years, which gives us a detailed pattern of how people's circumstances change as they grow older. There is an equivalent study in Northern Ireland, though it's younger, and so there are less data available. There have been aspirations to generate similar studies in Wales and in Scotland, though they have not really taken off yet.
And in terms of the study in Northern Ireland, has there been analysis of the data collected during that particular study? And if so, what's happened to that?
Yeah, so both the English study and the Northern Ireland study collected data on COVID experiences during the pandemic. There were some data also collected in Scotland during the pandemic, though that was much more partial. The Northern Irish data ended up included in a consortium of studies that were basically longitudinal studies that had pre-COVID data and during COVID data. So it was included, the data from the Northern Ireland study were included in that consortium.
Thank you. Intersectionality. You tell us at paragraph 20 that risk is not evenly distributed across the older population. As you've already made mention of, socioeconomic factors strongly relate to the experience of health, particularly in older ages. And you say this, consequently, the socio-economic position is related to the risk of both influenza-related morbidity and influenza-related mortality. And was that reflected throughout the pandemic?
Yeah, so the same pattern was present during the pandemic, yeah.
Thank you. Prior knowledge of the vulnerability of older people to an influenza pandemic, you say that that was recognised, that's at paragraph 14. And at paragraph 15, you say that the annual influenza vaccination that was recommended for older people in certain clinical groups also reflected an understanding of the vulnerability that those groups would have to the COVID-19 pandemic.
Yeah, correct. For some time, we've had a very clear understanding of the increased risk of influenza serious illness and influenza mortality for older people. This is particularly for people aged 75 and older, and particularly for older people who have some other chronic illness.
Thank you. The Clinically Vulnerable Families Group have prepared and provided us with a witness statement. We don't need to display this now, but at paragraph 85 of that statement, which I think you've had the opportunity of reading, they confirm that older age was one of the strongest and most consistent predictors of severe outcomes from COVID-19, and that data from the Office of National Statistics showed that the risk of dying among those aged over 80 was far higher than for younger groups. Do you agree with that?
Yes.
Yes, and that despite this, age alone was not identified as a criterion for shielding, that the shielding programme focused on a narrower group of conditions judged to carry exceptional risk, but excluded the much larger group of older people. Is that right?
Yes, but we need to consider carefully about the process of recommending shielding, because this obviously is a very dramatic change in people's living circumstances. And in doing that, also recognise that some groups of older people are particularly vulnerable. So those living in poorer areas, poorer older people, ethnic minority older people, and those with chronic conditions that might be summarised under the term frailty.
Thank you. I want to move now to access of older people to intensive care units, and noting that this is something which has been previously discussed in the inquiry in earlier modules. You nevertheless have found clear evidence that the policies were put in place to reduce the access of more vulnerable older people to intensive care units. Is that right?
Yes, that's correct. A crude clinical screening tool called the Clinical Frailty Scale was used to screen people as they entered hospital to determine their fitness for potential ICU treatment. And if they failed that screening, if their frailty level was too high, then they were deemed not eligible for ICU treatment.
Thank you. Risks faced by older people living in care homes and those awaiting discharge from hospital. Again, this is something that's been touched upon by Module 6. But you say at paragraph 55 that people living in care homes, and therefore a population with high levels of frailty and who were consequently at risk of complications or mortality if they were affected with COVID-19 throughout the pandemic, beyond improving access to tests for infection and improving access to personal protective equipment, no additional measures were taken to protect care home residents.
Yes, so I would go slightly further than that and say that care home residents were put at risk. So prior to the pandemic, it's very clear, and I detail some of the evidence, it's very clear that people living in care homes have a high risk of severe illness and death from a respiratory virus such as SARS-CoV-2. This has been very well documented. The rationale, the reasoning behind that has also been very well documented, including by the then Deputy Chief Medical Officer.
Yes.
And consequently, that's a group of people who were in effect identified at high risk of severe illness and mortality from COVID-19, during COVID-19 pandemic.
Thank you. In terms of access to healthcare and disruption to access to healthcare, at paragraph 78 you say that there is clear evidence that older people had their access to healthcare disrupted and that this disruption was greater for those in greater need. And the way in which you describe it is in this way. It is imperative that in the event of a future pandemic policy, there should be focus on ensuring continuity of care, and there should be a targeting of those whose care is most likely to be disrupted, particularly poorer older people.
Poorer older people and poor older people with multiple chronic conditions were the two that the strongest evidence was present for in terms of disruption of continuity of care. Continuity of care, I'm sure, is a theme. Indeed, Laia also raised it. Continuity of care is a theme that I'm sure is consistent across the inquiry. How to maintain continuity of care for the most vulnerable.
Thank you. Would you agree that, in line with the JCVI guidance, older age should be recognised as a clinical vulnerability to COVID-19 due to the increase in risk caused by ageing itself, including immunosenescence?
Yeah, so immunosenescence isn't necessarily a word I would use. I tend to use the word frailty, which overlaps with immunosenescence. But nevertheless, older people are at higher risk, as asked.
Thank you. What is the COVID-19 decision support tool?
So the COVID-19 decision support tool was a tool that ended up not being used but was widely distributed, that identified characteristics that would lead people along a particular treatment pathway. I think what's crucial in relation to that is that if you're old, you're very likely to end up with a score that leaves you onto low-intensity treatment or even a palliative care treatment pathway. So it captures age as one criteria itself, then chronic conditions, which older people are more likely to have, and level of frailty, which older people are more likely to have. So, you know, once you get to 65 and have a couple of chronic conditions, you're beginning to get to the stage where you are not deemed appropriate for intensive treatment. Now, I stressed that this tool was not used, but it did inform practice, and other tools that were used followed similar rationale.
Thank you. Social exclusion, isolation, loneliness and mental health. You tell us at paragraph 87 that during the pandemic, older people, and particularly those identified as clinically vulnerable and at high risk, were advised to self-isolate, as we know, and to avoid face-to-face contact with others. Did that lead, in your experience from your research, to higher levels of isolation, loneliness and poor mental health?
Exactly. So research conducted over the pandemic showed those changes from pre-pandemic to post-pandemic.
Thank you.
Sorry, to during pandemic, pre-pandemic to during pandemic.
In terms of volunteering, you say that the engagement of older people in volunteering activities is not only an important social contribution, it's also a marker of the extent to which older people are socially included. Did the pandemic affect that?
Yeah, so levels of volunteering dropped really quite dramatically during the pandemic, levels of volunteering of older people. It varies slightly across different groups of older people, but they were dramatic declines in levels of volunteering.
Thank you. Factors increasing risk of social isolation and loneliness. What do you say about health and level of wealth? Are they usually associated with social isolation and loneliness? And was that reflected within the pandemic?
Yeah, so they are both strongly related to levels of isolation and loneliness. The poorer you are, the poorer your health, the more likely you are to be isolated or lonely.
Yes.
And that persisted over the pandemic. It's hard to unpick how much it changed, but it certainly was consistent over the pandemic.
Thank you. Mental health and well-being and other factors exacerbating risk. The Disabled People's Organisation evidence and their submissions that the inquiry has received detail how those with poor health, in particular disabled people, faced a change in risk of social isolation during the pandemic, in that the risk became considerably higher due to both the decrease of caring services provided within the home, but also the cessation of respite and social activities for disabled people outside of the home. Did you find that respondents with poor health experienced a large increase in the prevalence of feeling socially isolated during the first COVID-19 wave, albeit this percentage was decreased during the second COVID-19 wave, and also that there was an increase in the prevalence of high subjective social isolation with a decrease in wealth?
Yeah, so that relates to my previous response.
Yes.
That appeared to be the pattern. The extent of that is very hard to determine with the data that we had.
And can you confirm, please, Professor, that the study overall concluded that respondents with poor self-reported health had a much higher risk of feeling socially isolated and lonely during the pandemic, and those in the poorest wealth quintile had an increased prevalence of social isolation and loneliness during the second COVID-19 wave?
Yeah, so that's correct, but I'll stress again that this pattern was also present pre-pandemic, and how far it amplified during the pandemic is hard to unpick.
Thank you. economic impacts, I think we have covered. Just perhaps to mention adjustment to retirement plans. Paragraph 133, you tell us that the financial consequences of the COVID-19 pandemic also caused concerns for older people in relation to their future finances, that close to half of those who were working thought that their retirement income would be lower as a result of the pandemic, and 14% thought it would be much lower, with very few expecting their retirement income to be higher.
Yeah, so this is a consequence of retirement income being dependent upon stock market performance.
Yes.
And stock market performance being poorer during the pandemic. Also relates to the amount of contribution you can make, and if and older people were particularly vulnerable to reductions in income during the pandemic. So yes, absolutely, and many had plans to delay their retirement date as a consequence.
Yes, thank you. Turning then to lessons learned that begin at paragraph 152 of your report. You confirm that your research and your experience has shown you that older people bore the brunt of the pandemic, that they are not simply a homogenous group, and that their experience or poor experience of the pandemic was influenced by overcrowding. You talk about digital services and the need to ensure that older people have access to such services and the ability to use them. You talk about access to medical services and social care. And you say finally at paragraph 165, there is a need to review the adequacy of data surveillance systems to inform policy development going forwards.
Yes, so just to pick up on if it's okay, we have time to pick up on a couple of the points there.
Yes.
In relation to digital, we haven't really talked about this, but older people are particularly likely to be digitally excluded, particularly
yes.
poorer older people and older people with poorer health. There are approaches to address this, and I think we need to think very carefully as we move to a more digitally dependent society that we begin to enable older people, and particularly poor older people, to have access to digital technologies. As I say, there are approaches to doing this done by a number of NGOs. In relation to the greater vulnerability of older people, just a couple of very crude statistics. More than 90% of the people who died during the pandemic were aged over 60. And this was particularly a significant proportion of those who died are in the older age groups. But it is those who are poorer, ethnic minority people, and those living in care homes or transferred into care homes who made up a large proportion of those deaths. 40% of the deaths during the first wave of the pandemic occurred in care homes.
Thank you. Professor Nazrou, my lady, that concludes my... I'm so sorry, I'm just being passed a message.
I think we've got Mr. Wagner now instead.
We have, yes. Yeah. You're ahead of me, my lady, as usual. Clinically vulnerable families and disabled people's organisations, please. Thank you.
Thank you very much, Mr. Dykel. Mr. Wagner.
If it's okay with you, it's Miss Cornalia is going to ask the question.
Oh, okay. Back to where we were. Miss Cornalia.
Thank you, Madam. Apologies for that. Professor Nazrou, you look at economic impacts in section 7 of your report. Are you aware of, and could you describe any examples of older people retiring early because they were not safe in the workplace during the pandemic?
So there's certainly a large amount of what I would describe as less formal evidence where people have reported on removing themselves from work, not being able to be furloughed, not being able to work from home, and therefore consequently removing themselves from work because of their fear of clinical harm. As of yet, the statistics behind this, as far as I know, you may know more than me, but as far as I know, the statistics on this have not yet been assessed. But it would not surprise me if we find post-pandemic, when we look at the data, that there will be a proportion of older, vulnerable people who have retired early.
Thank you, Professor Nasru. Madam, may I ask a very brief follow-up question in relation to the use of the word fear?
You may, but I am going to have to get tight on follow-up questions. I'm afraid they don't always act as follow-ups in my view. You may.
Just a very brief question. The use of the word fear, how far would you say that these issues with early retirement were down to fear as opposed to the absence of adequate protections in the workplace?
Well, I think the two go together. So you will be concerned about, so if you're clinically vulnerable, you're concerned about your health, and then if you don't have adequate protection, then those concerns will be amplified.
Thank you, Professor Nasru.
Thank you very much. And now, Ms. Beattie.
Professor Nasru, I ask questions on behalf of National Disabled People's Organisations. You refer in your report to older disabled people accessing social care and to there being reduced access to sources of support, poorer access to social care, a rise in unmet need and intensification of caring roles and activities. My question is about whether reduced social care put older disabled people at greater risk of abuse, including where older disabled people were receiving care potentially in the context of domestic abuse, and during lockdown the abuser may have been or newly become their only carer upon whom they may have been particularly reliant or even entirely dependent.
Yeah, so just to clarify, intensification of caring roles refers to informal caring roles who are largely family and friends, and hence the concern of the potentially increased risk of domestic abuse in those caring roles. We do know that the majority of elder abuse is conducted by a spouse or relative. As far as I'm aware, we do not know how that changed during the pandemic, but clearly the risk was there.
And I think Professor Beccaro has referred to, in her evidence, to a notion of what a common picture of what domestic abuse looks like. But do we really need to take into account this as well? To include older people, absolutely. And I would again argue that there are data shortages here. We do need more research around the experience of elder abuse, or the prevalence and experience of elder abuse. Thank you, my lady.
Thank you, Ms. Beattie.
My lady, that completes today's evidence. Perhaps it's just worth reminding ourselves that although we've only highlighted certain parts of the 3 expert reports that have been provided today, provided and discussed today by Professors Beccaro and Nasru, of course, the whole of the reports will be published and will be taken into account by my lady in formulating our module report.
Thank you, Ms. A point well made. Thank you. Professors, I think you know that, but just to reaffirm and echo what Ms. Blackwell's just said, do not worry if we haven't gone over everything in your reports in the kind of detail you would have liked, as you'll appreciate. We have to just focus on the main highlights for the oral evidence, but I promise you I will take into account your extremely helpful report, and thank you very much for the help you gave last time and for the help you've given again for this module. I'm really grateful.
Thank you.
Thank you. Very well. I shall return for 10 o'clock tomorrow, please.
Thank you, my lady.